We spend so much time watching our pets, you know, the wagging tail, the purr, the zoomies. But beneath all that visible stuff, there's this incredible silent world of hormones really calling the shots.
Absolutely.
And when those chemical messengers get out of tune, the impact on our furry friends can be really surprising, can it?
It really can. We're diving into the world of endocrinopathies today, basically. Think of them as diseases affecting the body's hormone-producing glands, the command centers, if you will.
Yeah.
And when these glands hiccup and produce too much or maybe too little of their vital chemicals, it just sets off this chain reaction throughout the whole system.
Okay, so in this deep dive, which we've tailored just for you, our listener, we're cracking open the guidelines on some of the most common hormonal imbalances we see in dogs and cats. For our canine pals, we'll be focusing on hypothyroidism. That's when the thyroid slows down, and then sort of its opposite, hypercortisolism, which most people know as Cushing syndrome.
Yeah.
And then the flip side of that, hypoadrenocorticism, also called Addison's disease.
And for our feline family, we're definitely going to explore hyperthyroidism, which is, a really common condition where the thyroid goes into overdrive.
Right. Very common.
We'll also touch briefly on some of the, let's say, less common feline issues mentioned in your sources, just to give you the full picture. Things like hyperaldosteronism, hypothyroidism. Yes, cats can get that too, though it's rare, and hyperadrenocorticism.
Okay. Our goal here isn't to turn you into a veterinary endocrinologist overnight, obviously.
No.
But more to pull out the crucial information from these detailed guidelines so you can really grasp what these conditions are all about, without getting totally bogged down in the medical jargon.
Exactly, making it accessible.
All right, let's unpack this. Let's start with a condition that affects, well, quite a lot of middle-aged dogs and can sometimes be a bit of a diagnostic puzzle. Canine hypothyroidism. What's the core issue here?
So canine hypothyroidism, at its heart, it's a deficiency. The thyroid gland simply isn't cranking out enough of the key thyroid hormones. We're talking primarily thyroxine T4 and also triiodothyronine T3. Okay. Think of these hormones kind of like the body's thermostats, regulating energy use metabolism in pretty much every single cell.
So what makes the thyroid gland decide to just take a break? Does it just wear out over time?
Not usually, no. The most frequent causes are actually the body's own immune system mistakenly attacking the thyroid gland. That's what we call immune-mediated destruction, or thyroiditis.
Ah, okay. Autoimmune.
Right. The other common cause is something called idiopathic thyroid atrophy. It's a bit of a mystery, honestly, but it's suspected that this might actually be the end stage of that long-term smoldering thyroiditis.
Interesting.
And what's really fascinating here is that there seems to be a genetic component, a nudge, in certain breeds that makes them more prone to these issues.
Ah, those breed predispositions again. It seems like genetics pops up in so many dog conditions. Which breed should we be particularly, aware of for hypothyroidism?
Yeah, the guidelines specifically highlight English setters, Doberman Pinschers, Rhodesian Ridgebacks, and also both Golden and Labrador Retrievers as having a higher likelihood.
Okay. Goldens and Labs. Always on the list, it seems.
They are quite common. The reason might be linked to a higher prevalence of certain autoimmune genes in those populations, but, research is still ongoing there. It's rare, but problems with the pituitary or hypothalamus can cause it too. But really, the vast majority comes from problems right in the thyroid gland itself.
Got it. So when do we typically see this starting? Is it something that happens in young puppies or more of a midlife kind of thing?
It definitely leans towards being a disease of middle-aged dogs. The average age when it's diagnosed, according to the data, is around 6.8 years old.
Okay.
And the development of signs is often really gradual, sometimes unfolding over months or even years.
Yeah.
That can make them super easy to miss early on.
Yeah, I can imagine. And those subtle signs can be really tricky. What are some of the key changes an owner might notice that could, raise a flag for potential hypothyroidism?
There's quite a range, actually. Skin and coat changes are very, very common. You might notice hair loss, usually on the trunk, that isn't itchy.
Okay. Non-itchy hair loss.
Exactly. Sometimes it's described as a rat tail, where the base of the tail loses hair, but the tip stays kind of bushy. The coat itself might look dull, maybe thin, and you could see increased oiliness or dryness of the skin. That's seborrhea. Some dogs also develop hyperpigmentation, like a darkening of the skin, and they can become prone to recurrent skin infections. Pyoderma.
Okay, so some pretty noticeable outward changes there. What about on the inside? Energy levels, personality.
Yeah, metabolically, dogs with hypothyroidism often become more sluggish, maybe mentally dull. They might show less enthusiasm for walks or playtime.
Okay.
They might gain weight even if their eating habits haven't really changed much, and they can even start seeking out warmer spots because they feel the cold more. Heat-seeking behavior,
Right.
less commonly, but still possible, are some neurological signs like a sudden weakness on one side of the face, facial nerve paralysis or balance problems, vestibular disease, or even a more generalized nerve issue called polyneuropathy.
Wow, okay. And what might a vet see if they just run routine blood work on a dog, maybe in the early stages? Any clues there?
Yeah, initial screening blood tests often reveal some, let's say, nonspecific abnormalities. The most common things are elevated cholesterol levels, hypercholesterolemia, and increased triglycerides, which is another type of fat in the blood.
Okay.
And sometimes you might see a mild anemia, specifically a non-regenerative anemia, where the body isn't making enough new red blood cells.
So, with all these potential signs and clues, how does the veterinarian actually nail down the diagnosis? Is it as simple as seeing a low thyroid hormone number?
That's the tricky part. While a low total thyroxine or TT4 level is definitely a key piece of the puzzle. I mean, a result in the upper half of the normal range makes hypothyroidism pretty unlikely. It's really crucial to understand it's not the only factor.
Right.
Things like the dog's breed, their age, certain medications, prednisone is a big one, and even other underlying illnesses or just stress can also cause those TT4 levels to dip.
Okay, so a single low TT4 reading isn't an automatic diagnosis then. What other tests do vets typically rely on to be sure?
That's where free T4 or FT4 and thyroid stimulating hormone TSH testing come in. These are often used to confirm things, especially when that TT4 level is kind of in the gray zone borderline.
Makes sense.
The guidelines suggest that if a dog has compatible clinical signs or those non-specific blood work changes we talked about, and they also have 2 out of 3 abnormal hormone levels. Typically, that's low TT4 and low FT4, along with a high or maybe inappropriately normal TSH. That combination strongly supports a hypothyroidism diagnosis.
Got it. 2 out of 3 abnormal plus the signs. So once a dog is diagnosed, what's the usual approach to getting their thyroid levels back where they should be?
The main treatment is supplementation with levothyroxine, which is just a synthetic form of T4.
Cool.
Initially, it's usually given twice a day, and it's really crucial that it's given on an empty stomach for the best absorption. If you give it with food, the body just might not absorb it as well, and you might end up needing a higher dose.
Good tip. Empty stomach.
Definitely. Later on, once the dog is stable, some patients might potentially be switched to just a once daily dose.
And how do vets keep tabs on whether the treatment's working, getting the dose right?
Monitoring usually starts about 4 weeks after starting the levothyroxine. A TT4 level is checked then.
Okay.
If the signs of hypothyroidism aren't improving, or maybe if there are signs the dose is too high, like restlessness or panting, then adjustments might be needed. Once the condition is well managed, TT4 monitoring is typically done every 6 to 12 months.
Right.
And for those dogs on a once daily dose, checking what's called a pre-pill TT4 level, basically drawing the blood sample right before their morning dose, that can help figure out if the dosage is adequate through the whole day.
You know, I've heard whispers that hypothyroidism might sometimes get diagnosed when it's not actually the underlying problem.
Yeah.
Why might that happen? Is that a real concern?
That's a very valid point. And yeah, the guidelines themselves acknowledge that overdiagnosis can be a concern. It's largely because so many of the clinical signs we see, like lethargy or weight gain, are pretty nonspecific, right? They can be associated with a whole host of other conditions. Trust, like we just discussed, interpreting those thyroid function tests can be a bit of a minefield because all sorts of non-thyroidal factors can mess with the results.
Right, the illness, the stress, the meds. The guidelines also mention this categorical approach to diagnosis. Can you give us a quick rundown of what that involved? It sounds helpful.
Yeah, it's a really practical way to think through the process based on what the dog is actually presenting with. So group 1 includes dogs who have those classic signs of hypothyroidism and a low TT4 level.
Okay.
For these guys, further testing FT4 and TSH is definitely recommended to really solidify that diagnosis. Breeds like, say, Beagles, Golden Retrievers, Dobermans, Great Danes often fit here if they're showing typical signs.
Makes sense. And what if a dog has that low TT4 but isn't really showing any of those classic signs?
Okay, that would fall into group 2. This can sometimes happen in certain breeds that just naturally have slightly lower TT4 levels, sighthounds, for example. Or it can happen with certain medications or during other illnesses, like we said.
Right.
In these situations, the advice is usually to just keep a close eye on the dog for any signs that might develop later, and maybe consider retesting their thyroid levels once they're feeling better from whatever else was going on, since that non-thyroidal illness can temporarily suppress the TT4.
Okay, monitor and recheck. And what about the opposite? A dog showing several signs that really point towards hypothyroidism, but their initial TT4 comes back.
Normal. That's group 3. Here, it's important to dig a bit deeper. You need to consider other potential reasons for those clinical signs first.
Okay.
Further thyroid testing might be considered FT4, TSH, maybe even checking for anti-thyroid antibodies to see if there's evidence of that immune-mediated thyroiditis lurking. In some tricky cases where TT4 and FT4 are maybe low normal and there are no antibodies, a TSH response test might give more info. If hypothyroidism is confirmed in this group, maybe through those extra tests, then the treatment with levothyroxine and the monitoring plan are basically the same as for group 1. Interestingly, if that initial normal TT4 was actually falsely elevated due to interfering autoantibodies, then FT4 becomes the go-to test for monitoring treatment effectiveness.
That's a really helpful framework. And one last point on this. What about dogs who might have other health issues going on at the same time?
Yeah, that's a really important consideration. The guidelines strongly stress that ideally, any endocrine testing for hypothyroidism, and really for the other conditions we'll discuss too, should be put on hold until any other concurrent illnesses are resolved or at least stabilized.
Why is that?
It just helps prevent us from misinterpreting results that might be skewed by the effects of that other illness itself. Non-thyroidal illness syndrome, they call it.
Got it. That brings a lot of clarity to canine hypothyroidism. Okay, let's switch gears now and talk about another hormonal balancing act, canine hypercortisolism, or as many know it, Cushing syndrome. What's the core problem happening here?
So with Cushing syndrome, the body is basically exposed to excessive levels of glucocorticoids, primarily cortisol. This can happen when the dog's own body starts overproducing cortisol.
Okay.
Or it can be because we're administering external glucocorticoid medications, like prednisone. That second type is what we call iatrogenic Cushing's, caused by treatment.
Right. And when it's the dog's own body making too much cortisol, the naturally occurring kind, what are the typical scenarios there?
Naturally occurring Cushing's is broadly split into 2 main types. The most common, accounting for around 85% of cases, is ACTH dependent.
About 85%.
Yeah, a big majority. This means the issue usually starts in the pituitary gland, typically a small benign tumor there that leads to an overproduction of adrenocorticotropic hormone, or ACTH.
Right.
This excess ACTH then acts like a constant go signal to the adrenal glands, telling them to pump out way too much cortisol.
And the other 15%?
Yeah. The other roughly 15% of cases are ACTH independent. Here, the problem lies directly within one or sometimes both of the adrenal glands themselves. Often, it's an adrenal tumor that's just autonomously producing excessive cortisol, completely ignoring the ACTH levels.
Diagnosing Cushing's. It sounds like it can be a bit of a detective game. The guidelines mention that the diagnostic tests have limitations, potential for false positives.
You're absolutely right. It can be tricky. All the diagnostic tests we have for Cushing's, well, they have their drawbacks. They can definitely be influenced by other illnesses or even just the stress of a vet visit.
Yeah.
That's why the guidelines really strongly emphasize that we should only be testing dogs when there's a genuine high clinical suspicion of Cushing's, typically if they're showing at least 2 or more suggestive clinical signs, or maybe have consistent abnormalities on their routine blood work that point towards it.
Okay, so don't just test because one number looks weird.
Exactly. And it's also a really good idea, if possible, to try and get any other existing health issues, like maybe diabetes or a urinary tract infection, under better control before diving into the Cushing's testing. Stabilize first.
Right, good point. So with those important caveats in mind, what's generally preferred initial diagnostic tests that vets reach for?
The low-dose dexamethasone suppression test, or LDDST, is usually the first-line diagnostic test recommended by the guidelines.
Okay, the LDDST. How does that one work?
So we take a baseline blood sample to measure the dog's initial cortisol level. Then we give a small, standardized dose of dexamethasone intravenously.
Right.
Then we take further blood samples, usually at 4 hours and 8 hours after the dexamethasone injection, to see how the cortisol levels have changed. In a healthy dog, that small dose of Dexsoups acts like a brake. It should suppress cortisol production.
Makes sense.
But in a dog with Cushing's, the suppression either doesn't happen at all or it's incomplete. Specifically, if the cortisol is still high at the 8-hour mark, that's suggestive of Cushing's.
And can that LDDST also give us clues about whether the Cushing's is coming from the pituitary versus the adrenal glands, differentiating the types?
It can offer some hints, yeah. If the cortisol level stays high at 8 hours, confirming Cushing's, the pattern of suppression at the 4-hour and 8-hour points might suggest pituitary-dependent disease, PDH. For example, if you see some suppression at 4 hours, but then it rebounds by 8 hours.
Okay.
However, a complete lack of suppression at both 4 and 8 hours doesn't definitively point to adrenal-dependent disease, ADH. You might need further investigations like an abdominal ultrasound to look for an adrenal tumor, or maybe measuring the levels of endogenous ACTH in the blood to really differentiate between the two if knowing the origin is important for treatment planning or prognosis.
Gotcha. What about the ACTH stimulation test, the ACTH stim? When is that test more likely to be used for Cushing's?
The ACTH stimulation test, or ACTH-ST, is generally thought to be less susceptible to interference from stress and other non-adrenal illnesses compared to the LDDST.
Oh.
So it's often used if the LDDST results are maybe inconclusive, but our clinical suspicion for Cushing's is still really high. It's also the go-to test if we suspect iatrogenic Cushing's, from giving steroids.
Right.
And it's also very important for monitoring the effectiveness of certain Cushing's treatments, which we'll get to. The test itself involves measuring cortisol levels before, and then 1 hour after, giving an injection of synthetic ACTH.
And what did the results tell you?
A significantly elevated cortisol level after the ACTH injection is consistent with Cushing's. Interestingly, if you get very low cortisol levels both before and after the ACTH, that can suggest iatrogenic Cushing's or possibly even ADH, the adrenal tumor type. But it's important to remember that ACTH-ST isn't as sensitive as the LDDST for actually detecting adrenal tumors in the first place.
Okay, that makes sense. I also saw mention in the guidelines about the urine cortisol to creatinine ratio, the UCCR. Where does that test fit in?
Yeah, the UCCR, it's a highly sensitive test. That means if the result is negative, it's quite good at ruling Cushing's out.
Okay, good for ruling out.
Exactly. But it's not very specific. It can give false positives, especially in dogs that have other conditions causing increased urination or even just stress. So it's most helpful as an initial screening tool in dogs where maybe our suspicion for Cushing's is relatively low. Perhaps dog just has an elevated alkaline phosphatase level on routine blood work, but isn't showing many other clinical signs.
Right.
And for this test, the urine samples are best collected by the owner at home, in a relaxed environment, ideally over a couple of days, to minimize that stress factor.
Makes sense. Okay, so once we actually have a diagnosis of Cushing's, what are the main ways we can treat it?
Well, for adrenal-dependent Cushing's caused by a tumor, surgically removing the affected adrenal gland and adrenalectomy is often the preferred treatment if the dog is a good candidate for surgery.
Right, big surgery though.
It is. And medical management is frequently chosen instead, maybe due to cost, potential surgical complications, or if the dog has other significant health issues. Historically, a drug called mitotane was a primary medication used for pituitary-dependent Cushing's. But nowadays, trilostane is much more commonly used. It's FDA approved for treating both pituitary and adrenal-dependent Cushing's in dogs.
Ah, okay, trilostane.
Yeah. While it's officially labeled for once-daily administration, there's actually quite a bit of evidence suggesting that giving it twice a day might be more effective for maintaining control throughout the day in certain dogs. The starting dose of trilostane is often lower than the range stated on the label, and really careful monitoring is absolutely essential.
Right, that monitoring sounds key.
Right.
How do vets actually monitor how well the trilostane treatment is working? Is it straightforward?
Monitoring Cushing's treatment. It's actually a pretty complex area, and honestly, there isn't one single approach that everyone agrees on is best.
Oh, okay.
While the ACTH stimulation test has been used traditionally to monitor both mitotane and trilostane, more recent research indicates that the actual cortisol level after ACTH stimulation doesn't always correlate that well with how the dog is clinically doing when they're on trilostane.
Huh. So the number doesn't always match the dog.
Exactly. And because the ACTH-ST is the definitive test for diagnosing the opposite condition, Addison's disease, low cortisol, its main role now in monitoring Cushing's treatment is generally considered to be checking that we haven't accidentally suppressed the cortisol levels too much, made them Addisonian.
Got it. So it's more of a safety check?
Largely, yes.
Huh.
Really, the dog's clinical signs, things like drinking, urinating, appetite, skin changes, energy level, those are the most important indicators of whether the treatment is on the right track and if any dose adjustments are needed.
Okay, look at the dog first.
Absolutely. Regular cortisol measurements are still recommended to help guide therapy, though. Usually either a cortisol level taken right before their morning pill, a pre-pill cortisol, or a post-ACTHST cortisol level, typically checked about 3 to 5 hours after they've had their trilostane dose.
Right.
Initial recheck appointments are usually scheduled around 2 weeks, then 1 month after starting treatment, and then maybe every 3 to 6 months after that, as long as things seem stable.
Okay. The guidelines also outline that categorical approach for diagnosing Cushing's, just like they did for hypothyroidism. How does that help navigate these often tricky cases?
Yeah, just like before, it helps tailor the diagnostic strategy based on the whole clinical picture. So Group 1 includes dogs that are showing those classic clinical signs of Cushing's and have consistent abnormalities on their routine blood work.
Like what kind of abnormality?
Things like an elevated alkaline phosphatase, ALP, maybe high cholesterol, dilute urine, possibly some protein in the urine, high blood pressure, and often a stress leukogram that's a specific pattern of white blood cell changes we see with excess cortisol.
Okay.
For these dogs, the LDDST is usually the recommended first endocrine test. Trying to figure out if it's pituitary or adrenal and origin differentiation can help with choosing the best treatment and understanding the prognosis, but as we said, trilostane can often be used effectively, even if we don't definitively differentiate.
Okay. What about dogs who have some of those blood work changes, like the high ALP, but aren't really showing the typical clinical signs, the potbelly, the excessive thirst?
Right. Those dogs fall into Group 2. In these situations, getting a really thorough history from the owner is crucial. You need to look for any subtle signs they might have missed, and importantly, make absolutely sure the dog isn't getting any glucocorticoid medications from another source, maybe eye drops or skin cream.
Good point.
Repeating the blood tests to confirm those abnormalities are consistently present is also important. We don't typically jump straight to endocrine testing for Cushing's unless the dog starts to develop those characteristic clinical signs. We might consider doing a UCCR test to help rule out Cushing's if there's a strong desire to investigate further. But remember, a positive result isn't definitive on its own.
Got it. And what if it's the other way around? A dog is showing clinical signs that make you think of Cushing's, but their routine blood work looks surprisingly normal.
That's Group 3. Again, the very first step is rule out any possibility of external glucocorticoid administration. Check everything.
Right.
If your suspicion for Cushing's is pretty low based on the overall picture, maybe just keeping a close eye on the dog for any changes might be the most sensible approach. You could also consider that UCCR to help rule it out. However, if your suspicion is high despite the normal blood work, then endocrine testing with an LDDST is generally recommended.
Oh.
If Cushing's is confirmed by the LDDST, then you'd consider further tests like ultrasound or endogenous ACTH to determine the origin. If the LDDST is negative, well, then you need to start looking for other underlying causes for those clinical signs.
Makes sense. Finally, for Cushing's, what about dogs who are already quite sick with other health problems, but also happen to be showing some signs that could overlap with Cushing's?
Yeah, Group 4 addresses these more complex patients. The absolute key here is to focus on getting the primary acute illness under control first, whatever is making them sick now.
Right. Stabilize first.
Exactly. We should typically delay any endocrine testing for Cushing's for about 2 to 4 weeks after the dog has started to improve. That's because the stress of being sick can sometimes lead to false positive results, especially with the LDDST. And it's really important to keep in mind that Cushing's itself doesn't usually cause things like a loss of appetite, vomiting, or diarrhea. So if those are the main reasons the dog is unwell, Cushing's is less likely to be the primary driver of the current illness.
Good point.
Now, in some situations where maybe the underlying illness isn't likely to improve without addressing potential endophase, Cushing's may be severe uncontrolled diabetes, it might be wise to consult with an internal medicine specialist to discuss the best timing and approach for endocrine testing in that specific case.
That's a really thorough and super helpful overview of Cushing's in dogs. Okay, now let's turn our attention to the other side of that adrenal coin. Canine hypoadrenocorticism, which most people know as Addison's disease. What's the fundamental problem happening here?
So Addison's disease is basically characterized by a deficiency in the hormones produced by the adrenal glands, primarily cortisol, the stress hormone, and often aldosterone, which regulates electrolytes and water balance.
Okay, so not enough hormones this time.
Exactly. The adrenal glands just aren't producing enough of these vital chemical messengers.
And what usually causes this deficiency? Why do the adrenals stop working properly?
The most common cause is believed to be direct damage to the adrenal cortex. That's the outer layer of the adrenal glands. And an autoimmune process, the body attacking itself again, is suspected to be the underlying reason in the majority of these primary Addison's cases.
Autoimmune again.
It seems to be a common theme in endocrinology. However, Addison's can also be triggered by the rapid withdrawal of long-term steroid medications. That's an iatrogenic cause, and it's usually temporary if caught and managed correctly.
Oh.
And less commonly, it can result from problems higher up with the pituitary gland, leading to what's called secondary hypoadrenocorticism, where there's just not enough ACTH being produced to stimulate the adrenals.
Got it. Are there particular dog breeds that seem to be more prone to developing Addison's?
Yes, definitely. The guidelines and other research consistently highlight several broods with an increased risk. These include Portuguese water dogs, bearded collies, standard poodles,
Okay.
Nova Scotia duck tolling retrievers, Leonbergers, Great Danes, and even Labrador retrievers pop up here too.
Interesting list. Now, the clinical signs of Addison's are often described as being quite vague. Sometimes they seem to come and go. What sort of things might owners observe?
Yeah, the signs can be incredibly variable and often really nonspecific, which honestly can make diagnosing Addison's a real challenge sometimes. Owners might report things like just general lethargy, maybe episodes of vomiting and diarrhea that don't seem to have a clear cause, increased thirst and urination, sometimes weight loss, and occasionally intermittent bouts of shaking or trembling. A really key characteristic, though, is that these signs can often wax and wane.
Wax and wane. How so?
Meaning the dog might seem to get better for a while, perhaps after just getting some fluids at the vet, or maybe even after getting a dose of corticosteroids for some other unrelated issue, only for the signs to come back later, maybe worse next time. It can be very confusing.
I can imagine. And I understand there's a much more severe and acute form of Addison's called an Addisonian crisis.
Yeah.
What happens during that? That sounds serious.
It is very serious. An Addisonian crisis is a true medical emergency. It typically involves a sudden onset of severe weakness or lethargy, often accompanied by significant and persistent vomiting and diarrhea, and it can quickly progress to collapse and shock.
Wow.
Immediate hospitalization and really intensive supportive care, IV fluids, correcting electrolyte imbalances, giving steroids are absolutely critical in these situations. It's life-threatening.
Okay, good to know. So how do veterinarians definitively diagnose Addison's disease, especially given those vague signs?
The gold standard, the definitive diagnostic test for Addison's, is the ACTH stimulation test, the ACTH-ST again.
Okay, same test as for Cushing's monitoring, but used differently here.
Exactly. It involves measuring the dog's cortisol levels both before and then after administering that dose of synthetic ACTH. In a dog with Addison's disease, the cortisol levels will be low both before and after the stimulation. There's little to no response.
Right. No response indicates the adrenals can't produce cortisol.
Precisely. It shows the adrenal glands just aren't capable of responding appropriately.
Are there any clues on routine blood work, maybe before you get to the ACTH stim, that might make a vet suspect Addison's?
Yes, there can be. A classic finding is an abnormal sodium to potassium ratio, specifically less than 27 on a standard blood chemistry panel. That can be very suggestive.
Okay, low sodium, high potassium.
Usually, yes. But it's really important to know that this isn't always present. In fact, in a significant number of Addison's cases, especially the atypical ones that only lack cortisol, these electrolyte levels might be completely within the normal range.
Oh, okay, so normal electrolytes don't rule it out.
Correct. Measuring aldosterone levels directly can also provide valuable information about the mineralocorticoid side of things. Another useful screening tool is a resting cortisol level. If that level is above a certain cutoff, typically around 2 micrograms per deciliter, it makes Addison's extremely unlikely, assuming the dog hasn't received any interfering steroid meds recently.
Okay, so high resting cortisol rules it out.
Pretty much. But a low resting cortisol level on its own isn't enough to make the diagnosis. You still need that ACTH stimulation test to confirm.
Got it.
And one other subtle clue, sometimes seen on a complete blood count, or CBC, might be a lack of lymphopenia. Usually stressed or sick dogs have low lymphocytes, but because Addisonian dogs lack cortisol, they might have normal or even high lymphocyte counts. It's just another small piece of the puzzle.
Interesting. Okay, so once Addison's is diagnosed, how is it typically managed long term?
Treatment really focuses on replacing the hormones that the adrenal glands are no longer producing adequately. For the cortisol deficiency, a low daily dose of a glucocorticoid medication like prednisone or prednisolone is usually prescribed. The dose is typically similar to what the body would normally produce under non-stressful conditions.
Okay, replace the cortisol. What about the aldosterone part?
Right. For dogs who also have that mineralocorticoid deficiency, the ones with the high potassium and low sodium, they'll also need mineralocorticoid replacement therapy. Desoxycorticosterone pivlet, or DOCP, is a commonly used injectable mineralocorticoid.
DOCP, okay.
It's usually given as an injection roughly every 25 to 30 days. Some research suggests that lower starting doses than what's on the label might be effective, and the exact dose and the frequency of injections are really guided by carefully monitoring the dog's electrolyte levels over time.
So regular blood tests are key for monitoring that.
Absolutely essential for DOCP dosing. Fludrocortisone is another option. It's an oral medication that actually has both glucocorticoid and mineralocorticoid activity. It can be used as an alternative, maybe if DOCP isn't readily available or if the injections are difficult for the owner.
Okay. The guidelines also present that categorical approach for diagnosing Addison's. How does that help in these often challenging cases?
Similar to the others, it helps structure the approach. Group 1 includes dogs that present with those classic clinical signs we talked about, the lethargy, the GI upset, and they have those characteristic electrolyte abnormalities on their blood work, the low sodium, high potassium.
Right, the classic picture.
Exactly. For these dogs, doing an ACTH stimulation test is the logical next step to confirm the diagnosis. And treatment will almost certainly involve replacing both the missing glucocorticoids and mineralocorticoids.
Okay. What about dogs who show up with those classic electrolyte abnormalities on routine blood work, but they seem perfectly fine, no clinical signs?
That would be group 2. In these situations, it's really important to have a thorough conversation with the owner first. Specifically ask about any subtle signs they might have overlooked, maybe occasional mild vomiting, slight lethargy, and also, crucially, rule out any non-genuine reasons for those electrolyte changes. Things like how the blood sample was collected or handled, or certain underlying diseases like severe kidney disease or whipworm infections can sometimes mimic Addisonian electrolytes.
Ah, okay. Rule out spurious causes.
Definitely. If no clinical signs are truly found and those other causes are ruled out, then simply monitoring the dog closely and repeating the lab work periodically might be the most appropriate initial approach. If the electrolyte abnormalities persist, or if clinical signs do eventually develop, then measuring a resting cortisol level or going straight to an ACTH stimulation test should be considered.
Got it. And how are dogs who present in the middle of that life-threatening Addisonian crisis approached diagnostically?
Right. Group 3 addresses the Addisonian crisis. The absolute immediate priority is stabilization. That means aggressive intravenous fluids, correcting shock, addressing severe electrolyte imbalances, and low blood sugar if present.
Okay, treat first.
Treat first, stabilize first. Dexamethasone is the steroid of choice to give initially in this situation because it provides that essential glucocorticoid support without interfering with the cortisol assay used for the ACTH stimulation test.
Ah, clever.
Yes. So you can give dexamethasone for stabilization before you actually run the diagnostic test. The ACTH-ST should then be performed as soon as the dog is stable enough to tolerate it. Measuring aldosterone levels might also be considered in these critical cases to fully assess adrenal function. Mineralocorticoid treatment, like DOCP, can be initiated once the patient is stable, has a confirmed diagnosis of Addison's, and their sodium level has started to come up, usually above 130 mQ/dL.
Okay. Finally, what about those dogs who present with some of those vague clinical signs we associate with Addison's? Maybe the waxing and waning GI signs, but they don't have the classic electrolyte imbalances on their blood work, the atypical ones.
These fall into group 4, often referred to as atypical presentations, or glucocorticoid deficient hypoadrenocorticism. If the clinical signs are really suggestive of Addison's, particular things like that episodic gastrointestinal upset that seems to be triggered by stress, or maybe an unexplained increase in thirst and urination, a resting cortisol level should definitely be checked first.
Okay, start with resting cortisol.
Yes. If that resting cortisol level comes back low, below that 2 micrograms per deciliter cutoff, then an ACTH stimulation test is absolutely recommended to confirm or rule out glucocorticoid deficiency. If the resting cortisol is higher than that cutoff, well then Addison's is very unlikely, and we should be exploring other potential diagnoses for those signs.
Makes sense.
And even in these atypical cases where the electrolytes are initially normal, it's worth considering testing for aldosterone deficiency as well, either initially or later on, because some of these dogs can eventually progress to also needing mineralocorticoid support.
That's a really clear and helpful breakdown of the canine adrenal disorders. Fantastic. Now let's shift our focus over to our feline companions and delve into feline hyperthyroidism. I understand this is a really common issue, particularly in older cats.
Yes, absolutely. Feline hyperthyroidism, or FHT, is incredibly common. We see it all the time, especially in cats that are middle-aged or older, say over 8 to 10 years old, typically.
Right.
It's caused by the excessive production of thyroid hormones, usually, almost always, due to benign growths. They're called thyroid nodular hyperplasia that develop in one or sometimes both of the thyroid glands in the neck. It's rarely cancerous, which is good news.
Okay, usually benign growths causing too much hormone. What are some of the typical signs that might make a cat owner suspect their feline friend has hyperthyroidism?
The classic signs often include a really noticeable weight loss, despite the cat having a good or even sometimes a ravenous appetite. They eat a ton but still lose weight.
Okay, weight loss with good appetite, classic.
Very classic. Also, an increase in their activity level or maybe restlessness, sometimes seeming hyperactive. Increased thirst and consequently increased urination, we call that PUPD.
Right.
And sometimes vomiting or diarrhea can occur. Some cats might also develop a poor or matted coat, maybe look a bit unkempt. And in many cases, but not all, a vet can actually feel a palpable nodule, a little lump in the neck where the thyroid gland is located during a physical exam.
Okay, so quite a few potential signs there.
Yeah.
And how is feline hyperthyroidism typically diagnosed? Is it similar to dogs?
It's often a bit more straightforward than canine hypothyroidism, thankfully. In most cases, simply finding an elevated level of total T4 or TT4 in the blood is sufficient to make the diagnosis.
Okay, high TT4 is usually enough.
Usually. However, in some early or maybe subclinical cases, or if there's a suspicion that another illness might be affecting the T4 levels, that non-thyroidal illness effect, again, the TT4 result might fall into a borderline or high normal range.
Right.
In those situations, measuring free T4 or FT4, specifically by equilibrium dialysis, can be very helpful. An elevated FT4 in that context supports the diagnosis.
Okay. What about TSH? Is that used in cats?
In very early stages of the disease, measuring thyroid-stimulating hormone, TSH levels, might have some utility. A low or undetectable TSH level would support a diagnosis of primary hyperthyroidism because the high T4, T3 should be suppressing TSH production from the pituitary.
Makes sense.
Interestingly, we can actually use the validated canine TSH test in cats for this purpose, as a feline-specific one isn't widely available everywhere. It's also worth noting that cats that still have measurable TSH levels despite being hyperthyroid might be at a slightly higher risk of developing hyperthyroidism after they receive treatment with radioactive iodine.
Oh, interesting.
But TSH levels aren't particularly sensitive for the initial diagnosis of hyperthyroidism itself. They're best used in conjunction with those borderline T4 or elevated FT4 results, or for looking at that post-treatment risk.
Got it. I understand that if feline hyperthyroidism goes untreated, it can have some pretty serious consequences for cats, right? It's not just weight loss.
Absolutely not. Untreated FHT is ultimately fatal. It can have significant negative impacts on multiple organ systems. The heart is a big one. It can lead to a condition called thyrotoxic cardiomyopathy, basically heart muscle disease caused by too much thyroid hormone.
Wow.
It can cause or worsen high blood pressure, systemic hypertension, which can then damage the eyes, kidneys, and brain. And it can also uncover or worsen underlying kidney disease. So it's really crucial to remember that any other health issues a cat might have, like heart disease or kidney disease, can't really be accurately assessed or effectively managed until the hyperthyroidism itself is properly addressed and controlled.
Okay, so treating the hyperthyroidism is paramount. We won't go into huge detail about the different treatment options here, as the guidelines indicate that's covered more deeply elsewhere. But Can you just briefly touch on the main approaches for managing FHT?
Sure. The primary treatment options generally fall into 3 categories. First, there are antithyroid medications, most commonly methimazole.
Methimazole, okay.
This can be given either as an oral pill or sometimes compounded into a transdermal gel applied to the ear. It works by blocking thyroid hormone production. It requires regular blood work monitoring for potential side effects like liver issues or blood cell count changes, and also for dose adjustments to keep the T4 in the target range.
Right.
Second is radioactive iodine therapy, often called I-131. This is often considered the gold standard or curative treatment. It involves a single injection of radioactive iodine that selectively destroys the abnormal thyroid tissue. It requires a short hospital stay for radiation safety. And the third option is surgical removal of the affected thyroid tissue, a thyroidectomy. This used to be more common, but is done less frequently now due to the risks of anesthesia in older cats and potential complications like damage to the nearby parathyroid glands, which regulate calcium.
Gotcha. The guidelines also outline a categorical approach for diagnosing feline hyperthyroidism, similar to the canine conditions. How does that apply here?
Right, so group 4 includes cats that are showing those clinical signs consistent with hyperthyroidism, the weight loss, increased appetite, etc. But their total T4 level comes back within the normal reference range.
The tricky ones.
Exactly. This can happen, like we mentioned, in very early disease, or if there's a concurrent non-thyroidal illness suppressing the T4, or just due to normal day-to-day fluctuations in T4 levels. In these situations, the recommendation is usually to repeat the TT4 measurement, definitely measure the FT4 level by equilibrium dialysis, and maybe consider checking the TSH level as well.
Okay, dig deeper with more tests. What about cats who have a confirmed diagnosis of hyperthyroidism based on their blood work, but they also have other significant underlying health conditions, like kidney disease or heart disease?
Okay, those cats fall into group 5. Because hyperthyroidism itself is such a serious condition and contributes to or worsens many other problems, the general recommendation is to proceed with treating the FHT even if the cat has these other concurrent diseases.
Treat the FHT first or concurrently?
Usually concurrently, but prioritizing getting the FHT under control. However, it's absolutely crucial to carefully monitor and manage those other conditions alongside the FHT treatment. Things like thyrotoxic heart disease need specific cardiac medications. Hypertension needs blood pressure medication. Chronic kidney disease, CKD, needs careful monitoring, especially as treating FHT can sometimes decrease kidney blood flow and worsen azotemia. Managing diabetes mellitus alongside FHT also requires careful balancing, so it's a holistic approach.
Right, managing everything together. And finally, what about cats who appear perfectly healthy, clinically normal, but then they have an elevated T4 level picked up on just a routine screening blood test, maybe during a senior wellness check?
Yeah, that's group 6, because we can sometimes see falsely elevated T4 values due to lab variability or other factors. The first recommendation here is usually to repeat the T4 test, and ideally using a more specific type of assay like a radioimmunoassay, RIA, or a chemiluminescent enzyme assay, rather than some of the in-house methods, just to be sure.
Okay, confirm the result first.
Exactly. If that repeat T4 level comes back within the normal range, then the cat should probably just be monitored with regular physical exams and repeat T4 testing, say, every 6 months, or sooner if they start to develop any clinical signs suggestive of hyperthyroidism.
Right.
However, if that T4 level remains elevated on the repeat confirmed test, even without obvious clinical signs yet, then treatment for hyperthyroidism is generally indicated to prevent those long-term complications we talked about. Catching it early is beneficial.
Okay, treat even if signs aren't obvious yet. If the T4 is persistently high, that covers the major conditions really well. Now, the guidelines also provide a brief overview of some less common feline endocrinopathies. Can you give us just a quick snapshot of those?
Certainly. Let's start with feline hyperaldosteronism. It's sometimes called primary hyperaldosteronism, or PHA, or Conn syndrome. This involves the adrenal gland producing too much aldosterone, usually due to a tumor on one of the adrenal glands.
Okay, too much aldosterone. What does that cause?
Key signs to watch for are hypokalemia, that's a low potassium level, which is often quite severe and frustratingly doesn't respond well to just giving potassium supplements. And the other major sign is systemic hypertension or high blood pressure, which can also be severe.
Low potassium and high blood pressure. How's it diagnosed and treated?
Diagnosis is confirmed by finding elevated levels of aldosterone in the blood plasma, and abdominal imaging, like an ultrasound, might show an adrenal mass. Treatment typically involves managing the high blood pressure, usually with medications like amlodipine, aggressively addressing the potassium deficiency with supplementation, and then, if possible, surgically removing the affected adrenal gland if the tumor is only on one side, unilateral.
Okay. And what about feline hypothyroidism? We talked about how common hyperthyroidism is, but what about the opposite in cats?
Right. Naturally occurring feline hypothyroidism is actually quite rare, especially compared to how common it is in dogs. If we just find a single low T4 level in a cat, we have to interpret it very cautiously because, as we've said, other non-thyroidal illnesses can easily cause T4 to drop in cats.
Right, the sick euthyroid effect.
Exactly. To make a diagnosis of true primary hypothyroidism in a cat, we generally need to see a persistently low T4 level along with an elevated TSH level, using either a feline-specific TSH test, if you can get it, or the validated canine TSH test.
And what are the signs if a cat does have it?
It depends on when it occurs. Congenital hypothyroidism, present from birth, can cause signs in very young kittens like stunted growth, disproportionately short limbs, a broad head, profound lethargy, constipation, problems with teeth eruption, and an abnormal sparge coat. It's quite sad to see.
Yeah.
In adult cats, if it develops later in life, which is very rare naturally, or maybe iatrogenically after hyperthyroidism treatment, the signs might be more like lethargy, unexplained weight gain, a poor, dry coat, maybe hair loss, sometimes decreased appetite, and a slow heart rate, bradycardia. Treatment, if diagnosed, involves supplementing with levothyroxine, just like in dogs, but at cat-appropriate doses.
And you mentioned iatrogenic hypothyroidism after treating FHT.
Yes, it's important to monitor thyroid levels after treating hyperthyroidism, whether it was with methimazole, surgery, or radioactive iodine, to make sure we don't inadvertently push them too far the other way and cause hypothyroidism. This is particularly important because iatrogenic hypothyroidism can sometimes negatively affect kidney function in cats who already have underlying CKD. So careful monitoring post-treatment is key.
Okay. And finally, what about feline hyperadrenocorticism, Cushing's disease in cats? Also uncommon.
Yes, feline hyperdrenocorticism, or HAC, is also quite infrequent. When it does occur, it's usually pituitary-dependent, PDH, similar to the majority of canine cases. And it's very often seen in cats that also have concurrent diabetes mellitus that's proving very difficult to regulate. That combination should raise suspicion.
Difficult diabetes plus other signs. Are the signs similar to dogs?
Not always. The classic signs of Cushing's that we typically see in dogs, the potbelly, excessive panting, symmetrical hair loss, are much less predictable in cats. Cats more often show things like thin, fragile skin that tears easily, recurrent infections, maybe muscle wasting, and that poorly controlled diabetes.
Okay. How do you diagnose it in cats?
The low-dose dexamethasone suppression test, LDDST, is generally considered the most reliable test for diagnosis, but you need to use a higher dose of dexamethasone in cats compared to dogs, typically 0.1 mg/kg intravenously. Lack of suppression confirms HAC.
Higher dose LDDST.
The urine cortisol to creatinine ratio, UCCR, can be a useful screening tool. Similar to dogs, a negative result makes HAC unlikely. But the ACTH stimulation test is generally not recommended for diagnosing Cushing's in cats because it's just not very sensitive. Many cats with HAC will have a normal response.
Okay, ACTH stim, not useful for diagnosis here. How is it treated?
Treatment primarily involves using trilostane, the same medication used in dogs. However, dosing in cats can be more challenging, often requiring administration 2 or even 3 times a day, usually given with food. The main goal is controlling the cat's clinical signs and improving the regulation of their diabetes. Careful clinical evaluation and diligent management of any concurrent diseases, especially that diabetes, are absolutely essential. If a cat's diabetes is proving really difficult to regulate, it should always prompt a search for other underlying issues, and HAC is one possibility, but there are others too.
Wow, okay. That covers a lot of hormonal ground. This has been a really insightful journey through these various endocrine conditions. The guidelines also dedicate a good section to the importance of the veterinary team approach and really clear communication with clients.
Yeah.
Why is that highlighted as so vital in managing these sorts of complex cases?
Yeah, it's incredibly important. Effective management of any endocrine case, really, relies heavily on a collaborative effort from the entire veterinary team. It starts right at the front desk. The receptionist plays a crucial role in initial triage, recognizing potentially urgent signs, and scheduling appropriate appointments and follow-ups.
Right.
And the veterinary technicians and assistants are absolutely essential. They are often the ones spending significant time obtaining a thorough and accurate patient history directly from the owner. And the owner's perspective, their observations of their pet at home, is just invaluable in these cases, especially when signs are vague or intermittent.
So true. And are there tips for getting that really good quality history?
Definitely. The guidelines suggest things like using standardized history questionnaires to ensure nothing is missed. Starting with open-ended questions, tell me about what you've been noticing before getting into specifics. Actively listening without interrupting too much, allowing for pauses. Using positive nonverbal communication, showing empathy, these owners are often worried, and using reflective listening, summarizing what you heard to make sure you understood correctly, and critically asking about all medications the pet might be receiving.
All medications, like what?
Everything. Prescription meds, of course, but also heartworm preventives, flea and tick products, any over-the-counter remedies, supplements, herbal products, eye drops, ear drops, skin creams. Even things the owner might be using on themselves that the pet could be exposed to, like topical steroid creams. These can all potentially interact with or even mimic endocrine conditions or interfere with testing.
Wow. Yeah, hadn't thought about owner creams. Good point. And how does that clear communication, both within the vet team and with the pet owner, impact the ongoing care of these animals with endocrine disease?
It's fundamental. Clear and consistent communication ensures everyone, vet, tech, owner, is on the same page regarding the diagnostic plan, the treatment strategy, the monitoring schedule, and what to expect moving forward, both good and bad.
Right.
For instance, knowing the precise timing of when an ACTH stimulation test should be performed relative to when a dog on trilostane received their last dose is absolutely critical for getting accurate, interpretable results. That needs clear instruction.
Yeah.
It's also vital to reinforce with owners that making adjustments to medication dosages like trilostane or levothyroxine or insulin is based on a combination of factors: the pet's clinical signs, what the vet finds on physical examination, and the results of laboratory tests. It's rarely based just solely on the numbers alone.
Right. Treat the patient, not just the lab value.
Exactly. And prioritizing the patient's comfort to minimize stress during veterinary visits is also incredibly important. As we've discussed, stress itself can significantly influence the results of many endocrine tests. Using stress-reducing techniques, maybe butterfly catheters for blood draws, ensuring calm handling, accurate blood pressure measurement protocols in a quiet setting, these all make a difference, not just for the pet's well-being, but for diagnostic accuracy too.
Makes total sense.
Ultimately, the entire veterinary team plays a pivotal role in educating the owner about the specific disease their pet has, the signs to watch for, both improvement and potential adverse events from medication, the overall goals of treatment, which is often management, not cure, and the absolute importance of consistent, lifelong care and monitoring for most of these conditions.
This has been a fantastic deep dive into what is clearly a complex but incredibly important area of pet health.
Yeah.
It's so clear that these endocrinopathies, while quite common, as you've said, can often present with such nonspecific and variable signs. And sometimes, as you highlighted, they can even have iatrogenic origins, meaning they're inadvertently caused by medical treatment itself.
Exactly right. And the fact that many of our patients, especially older ones who are prone to these conditions, often have other underlying health issues going on simultaneously, comorbidities like kidney disease, heart disease, arthritis, dental disease, that just adds another layer of complexity to both diagnosing and managing these endocrine disorders effectively.
Yeah.
That's precisely why thorough, appropriate diagnostic testing, coupled with taking the time to get a really detailed and accurate patient history from the owner, are just so crucial for navigating these often challenging cases and ultimately achieving the best possible outcomes for our beloved companion animals.
So I think the key takeaway for you, our listener, is that while endocrine disorders in your pets can certainly seem complicated and maybe a bit daunting, they're often very manageable with a good understanding of the specific condition, and most importantly, by working closely and collaboratively with your veterinary healthcare team. If you happen to notice any of the signs we've discussed today in your own furry family members, the changes in thirst, appetite, weight, energy, skin, whatever it might be, please don't hesitate to reach out to your veterinarian for a comprehensive evaluation. Early diagnosis makes a difference.
Absolutely. And perhaps a final thought for you to ponder. Thinking about the incredibly intricate and delicate balance of hormones constantly working within our pets really underscores the significance of proactive health monitoring, especially as they age, and maintaining that open, honest, two-way communication with your veterinary healthcare team. They're your partners in your pet's health.
Well said. And who knows? If there's enough interest from you out there listening, maybe we can dedicate a future deep dive to exploring some of the more specific aspects of these fascinating conditions. Maybe treatment nuances or monitoring challenges, or even delve into other related topics in the wide world of veterinary endocrinology.
Sounds like a plan.
Thanks so much for joining us for this deep dive.